Hello friends, this is Dr. KV Singh, and in this video I'll be demonstrating you a case of NS3 plus grade cataract, in which I'll be demonstrating a horizontal direct chop technique. And I am presently working at ASG Super Specialty Eye Hospital, um, and I am an anterior segment consultant. I generally take care of cornea and glaucoma in my hospital. In by now I have already cleaned and draped my eye, and I'm now cleaning the ocular surface with the PSS. Thorough cleaning of ocular surface is very important because that removes all the residual betadine and any kind of discharge that is present. I'm making side port incision. I use 23 gauge MVR blades to make them because the architecture of the wound is very nicely made and the sizing is also maintained. I do all my case of cataract surgery in case there is if I have only cataract surgery to do. If it's not a combined case, then generally I do it in topical anesthesia, and I augment it with 1% intracameral lignocaine. I generally don't use a trypan blue dye to stain the anterior capsule, but whenever I am demonstrating any case, then I like to stain the anterior capsule with trypan blue dye. That delineates it nicely, and that explains my steps very nicely. So before making my main incision, I like to fill the AC with visco. It tightens the eye, and the architecture of my main wound is nicely made. I like to make a biplanar incision, and I like to keep a track length long. I've coated the epithelium with visco so that the visibility increases, and now I'm going to take 26 gauge and bent needle to make the capsulorhexis. I have tried many instruments that includes Utrata forceps, micro capsulorhexis forceps, Haldipurkar forceps, and all those kind of things. But what I found that 26 gauge needle, bent needle, works best in my hand, and I am able to make good capsulorhexis of my desired size and my desired placement. I like to keep my capsulorhexis around 4.5 mm to 4.75 mm. This gives a nice overlap, and this is very important specifically in cases of multifocal IOLs and toric IOLs, and because this maintains the ELP very nicely and refractive results are very good. This particular step, hydrodisc dissection, I've already completed, and I think this particular step is one of the most important step in eye, because if you want to do a surgery fast, then you have to clearly separate your nuclear material, cortical material, from the capsular bag. Now, before introduction of phaco probe inside the AC, I refill the AC with visco, and in case it's like this was a slightly more denser cataract than what I expected, so I use side port Sinski hook from side port to rotate the nucleus. I use early phacoemulsification for doing my cases. I found it to be very effective, very efficient machine. It does not have much functions, but whatever is required, it does wonderfully well. So in this now, I'm showing a horizontal direct chop technique in which I impale the center part of the nucleus with my phaco probe, and I take my 2.5 mm Sinski to the periphery, and that chops the nucleus. Because this was a bulky nucleus, so I started engulfing from the very start. Otherwise, I generally make small pieces of the nucleus and then only I start engulfing. And my parameters are generally 350 vacuum, 60 phaco, and around 35 flow rate. And because early the AC is not very stable, so I like to keep my parameters low, and because I can regulate the amount of ultrasound going with my foot switch, so I keep it slightly on the higher side, that is 60. And now you must have seen I have already managed the nucleus, and I am now rotating the epinucleus to be engulfed, and this is greatly helped by my 2.5 mm ball tip chopper. This protects the PC and also protects the endothelium from the flying nuclear pieces. I started using horizontal chop technique around 4 years back by seeing Brazilian surgeon Neto Rezzotelli. Earlier than that, I was a vertical chop surgeon, and that thing particular technique changed my life. I'm able to do very fast surgeries, and my results are exceedingly well. So now its time has come for the irrigation and aspiration of cortical material. I use bimanual. First I introduce the irrigation from my right side, and start engulfing of cortical material from my right side. Because after this I'll change hand and I'll keep my irrigation in my left hand, and my right hand would be free to inject IOL inside the AC under irrigation only. So that aids in a single go. I don't have to change my hands, and I can put a IOL in the bag under irrigation efficiently. Does not waste my time, no wasted movements. And now the time has come for implantation of IOL. As you can see, the cortical material are nicely done. I like bimanual IA because this gives a 360 access to the capsular bag, and I am able to clean it very nicely. So now my assistant hands over the IOL to me in my right hand, and at one go I am able to implant it in the capsular bag. This was a multifocal case, and in multifocal case, as I already told you, that it's very important to maintain the ELP. And how do we do that? By getting a good overlap of the capsule on the IOL. You must now appreciate that my IOL is 360 degrees surrounded by the capsular margin, and now I'm cleaning the AC. So in a multifocal case, there are two things which you must do. First, remove the visco completely, because I've implanted the IOL under irrigation, so that step is generally not required. And I center the IOL nicely. You can see the Purkinje image lies in the central ring, and my IOL is nicely centered. I'm closing the now sideport incision first by stromal hydration. That forms my AC, and after that I'll be irrigating the anterior chamber with the BSS that removes whatever amount of visco left, and this gives me squeaky clean anterior chamber next morning. When I finish it, then I hydrate the entry wound with a small amount of diluted moxifloxacin solution, and that's how I am able to close my case. I always like to hydrate the superior wall as well. And after this, I check my AC I for pressure. I generally don't like to close in a very tight eye. I like to keep it physiological, and I don't put any kind of bandage after I finish my surgery, because I do almost all my surgeries in topical mode only. So now this is my surgery is done, and I hope you liked it. In case you did, please consider subscribing. Thank you guys. Jai Hind. And I'll be coming and explaining you other videos as well. Thank